Hi, my name is Michael Diminick. I'm an orthopedic surgeon with OrthoVirginia in Lynchburg, Virginia. And I'd like to welcome you here today and spend a few minutes talking about hip and knee arthritis and the different treatment options to consider when we're evaluating you. I want to give a shout out to my OR team. They're waiting for me to get over there to do some surgery this afternoon. So thanks for the time to spend with you. So I do predominantly hip and knee replacements, and I've been in practice here with OrthoVirginia for about 20 some years now. And it's been an incredible practice here, and here in Virginia and Lynchburg or all over the state of Virginia. I'm very happy to be a part of OrthoVirginia, be able to do things like this to educate our patients. So what I like to talk to you today about is hip and knee arthritis, hip and knee surgery. That's the most common problem that people come in to see me about. So I thought that'd be a good place to start. So hip and knee arthritis is a term that gets thrown around quite a bit. What we're really talking about, people think of arthritis, when you hear itis, you think about inflammation, but we're really talking about damage or destruction of the joint that brings patients in. And patients will come in all varying levels of damage to the joint, from very minimal to a patient who has just total destruction of the joint with tremendous pain and limitation of function. So we'll see patients anywhere throughout the course of the disease process and treat them accordingly. So if we look at a knee, for example, this is a model of a knee, and it's perfectly smooth. The cartilage in the knee on both surfaces, on the femur and the tibia, is perfectly smooth. Studies have shown that it's 10 times smoother than ice rubbing against ice. So in a normal situation, it's just glistening, perfectly smooth. It looks like the end of a chicken bone when you're in a knee that has no arthritis. Would be in a knee in that situation, for instance, if someone had an injury to their meniscus and we're doing arthroscopic surgery in a young person where the cartilage is going to be perfectly smooth. As people develop damage to their knee joint, there'll be progressive damage to the cartilage, and it'll start to show signs of wear and tear, or they're at arthrosis that I was talking about. So here you can see divots and craters in the knee, and it typically progresses in a classic fashion until you get to the point where the knee will show total loss of cartilage, where down to the bone, you'll have the bone of the femur rubbing against the bone of the tibia. The meniscus is the cushion between the bones, and that's often damaged as well. But by the time you get to destruction of the cartilage, where you get bone against bone, that any damage to the meniscus, we're beyond that in dealing with the arthritic type of symptoms. So whether it's for the hip or the knee, when patients have symptoms, they'll have pain with walking, pain with weight bearing. They'll have limited range of motion. Patients who have problems in their hip will typically have groin pain. A lot of patients come in and they say, oh, my hip hurts, and they're pointing to the side of their hip, or they're pointing to their back pocket. But people who have arthritis in the hip, it's generally going to be pain in the groin, difficulty getting dressed, putting their shoes and socks on, difficulty getting in and out of the car. Patients with knee arthritis will have pain with weight bearing. Typically, it's on the inside part of the knee, where your two knees would rub together. That's the inside or medial part of the knee, is where knees typically start to wear down first. And those patients will, again, have limited motion, pain. They'll start to lose motion where the knee can't straighten out all the way or can't bend as far as it used to. They'll have pain at night or pain at rest, which can become very troubling and disabling. So how do we go about evaluating, working up patients who have this? So you'll come in, of course, we do the history and physical. The history is where we learn how it's bothering you, what effect it's having on you, what treatments you've done so far. We examine you and then obtain x-rays. Usually plain x-rays are enough in patients with arthritis to give us the information we need. Occasionally, if the x-ray does not look like it has significant amount of damage, we might get an MRI in that situation to look at the cartilage and the ligaments. But in the vast majority of patients, the plain just radiographs or x-rays are sufficient. So when we evaluate you, we determine what the problem is. Then the treatment options. There's things that you can do, and there's things that I can help you with. So in terms of ways that you can help yourself, so one is staying active. So maintaining your strength, maintaining your range of motion is paramount, and can't be emphasized enough. You can use knee braces. There's all sorts of knee braces. So the fact that there's so many means that not one is perfect for everyone, but a lot of times it's trial and error to see whether a knee brace would help. Most patients could wear them for a couple hours at a time, but after a couple hours, they bunch up, they get hot, they start to fall down. So usually a couple hours here and there is what people will do with the knee braces. Weight loss is a significant issue, and it's one of the things that you have control over. Your weight is multiplied by 4 at the joint surface for instance, when you're going up and down stairs. So for every 5 pounds that you gain or lose, that's 20 extra pounds of pressure across the joint. So the good thing is losing just a little bit of weight, you multiply it by that factor of 4, so you get much more bang for your buck. But losing weight is critical. And I have many patients who, just by losing a little bit of weight, their symptoms can be significantly improved. Unfortunately, with the new medications that are available now, patients are having some more success losing weight. And there's others that you go through bariatric surgery and lose enough weight to take a significant amount of pressure off of their knee joints. Other things that you can use would be a cane. No one likes to use a cane, makes them look old. But a lot of my patients, I tell them the way they're walking, you're not fooling anybody. So if you can use a cane to take a pressure off that joint, your pain will be less, your mobility will be better. So again, to recap, the things that you can do, that's maintain your exercise level for strength, range of motion, use a brace or a cane, and control your weight where you can get your weight under control, taking pressure off the joint. When you get to me, things that we can help you with are more with, again, we can work with the range of motion, strength, and with physical therapy. So some patients have a difficult time exercising on their own, so physical therapy can be effective at helping with your strength and range of motion, and can definitely improve patients' symptoms. So physical therapy would be something we would discuss and possibly recommend that. Anti-inflammatory medications are a hallmark of the treatment with of what we do. So predominantly I start first with a topical anti-inflammatory. The one I use is Voltaren gel or diclofenac, you may have heard of. So it's topical, it's over the counter. It also comes as a prescription. I like it because of its safety. So you can apply it 3 or 4 times a day, and when it works, it's fantastic. Only about 6% of it is absorbed into your bloodstream compared to when you take pills. So it's much safer on your kidneys and stomach, heart, than when you take oral medication. So I like to start with that, particularly in the knee. The knee is more superficial, so that medication can penetrate the joint. It's not quite as effective for the hip, because the hip has all the big muscles surrounding it, and it's harder for the medication to penetrate the joint. So first would be the topical. Next is oral anti-inflammatories. So anti-inflammatories or NSAIDs, that's things, a class of drugs like Motrin and Aleve. So that's over the counter, but we also have prescription forms. So there's some like Celebrex or Meloxicam, Mobic, which are once a day medications. I like those medications because it's easier to dose. When you take ibuprofen and you take 3 or 4 of those at a time, you tend to be reluctant to take those 2 or 3 times a day because of the concern about side effects, irritating your stomach and things like that. So Celebrex is safer, particularly on your stomach, and you don't have to redose it. So I like to go with that. It's easier to get patients to take it. It's easier for compliance, and it's tolerated better because it does not bother your stomach. So that's the second way to get an anti-inflammatory. And then the third is with the steroid injection. So steroids or corticosteroids are injected directly into the knee. So they're an anti-inflammatory, the strongest anti-inflammatory. The NSAIDs, that stands for non-steroidal anti-inflammatory. So the cortisone is an actual steroid. And there's different types of medications. We tend to use Kenalog, which is tolerated very well. So that can be injected into the joint. It usually takes 2 or 3 days for that to start working and can last for several months at a time. So patients tend to do very well with the cortisone injections. So that's something that can be repeated every 3 or 4 months if it's lasting for 3 months at a time. So there are the 3 ways to treat it with the anti-inflammatories: topical, oral, and then the intra-articular injection. There's some concern about the side effects or the deleterious effects of the cortisone injection on the cartilage. And that's certainly something that we keep in mind for sure. In a young person whose cartilage is perfectly healthy, an injection may be administered for different reasons, but you minimize that in those injections in younger, healthy cartilage. By the time you have cartilage destruction, like I showed on those models, then the damage is already done, and we're trying to preserve the function, help with the pain, and any further destruction of the joint, I think, is usually minimized. Occasionally, it can, I've seen some patients who have a flare-up of arthritis even with an injection, but for the most part, they're well tolerated without causing significant further damage. Beyond that, so that would be the first line of treatment. There are other injections. There's another type of injection called hyaluronic acid. So this is a lubricant. It's similar to what's found naturally in your joint, and it can be injected. Works differently than the cortisone. It stimulates cells in the joint to produce the natural synovium fluid or the lubricating fluid within the joint. Works differently than the cortisone, so it takes up to 4 to 6 weeks. And that does not work in everybody. It only works about 60% of the time. When it does work, it can last for 6 months. So it can last longer than the cortisone when it does work. But the cortisone works faster. It works in almost everyone, at least for some period of time, and can be repeated in 3 months or so. The hyaluronic acid, you can only do every 6 months if it lasts for 6 months. The other issue with that is when you get to the point where you do have bone against bone, it's not approved by Medicare, and Anthem doesn't cover it, so it can't be used in every situation. Many times patients come in really when it's at the end stage and it's bone against bone and they're really at the point where they need surgery. They want to try the gel injection. But if you're at the point where it's bone against bone, there's no space in there, it's not going to work, so it's not approved. So it works better in my hands. I think it's better when there's less severe arthritis, so earlier on it could be effective. After that, there are more novel and experimental things that are being done. You may have heard of PRP or stem cells, and they're being used more. Right now, it's mostly experimental, and so far, there's nothing that's restoring cartilage. So that's what I think people who do a lot of PRP injections or stem cells lead us to believe that that's going to restore the cartilage. But so far, there's nothing been proving that it can restore the cartilage once that it's damaged. It can help with the symptoms for sure, much like the cortisone or the hyaluronic acid can. So they can help with the symptoms as well. So at this stage, I'd say they're disease symptom modifying. So they modify the symptoms just like any of the NSAIDs, cortisone, hyaluronic acid. They modify the symptoms, but nothing yet is modifying the disease, meaning that it reverses the arthritis or the damage to the joint that you already have. So these treatments can last from weeks to patients for years, so we can manage without getting to the point where their symptoms are so severe that they need a knee replacement or a hip replacement. But what's happening is you're going downhill in terms of function, your mobility. As patients get more severe, their walking steps get less. You can track that on your phone. You can see over time the steps that you're taking, how that diminishes over time as the symptoms get more severe. You stop doing the things that you enjoy doing just because it's too painful or too much of a hassle to get around to go to your grandchild's ball game or something like that. So you start to have this downhill descent. And if you do surgery too early on in the disease, if we're trying to get up to this level in function and pain relief, and we're just going down early on, there's only a little bit of gain to be had from doing the surgery, and you have all the risks and hassles of undergoing surgery. So patients oftentimes don't appreciate the improvement because there's not great improvement. If you wait too long till you're way down and dig yourself into a ditch, it's hard to get out, to get high enough improvement to get back to where you want to be. So there's some point along the descent in your function and your level of pain that you'll decide it's finally time to have surgery. If you ask most surgeons, we say you'll know when you'll know, and it sounds like it's a joke or a riddle, but that's really the fact of the matter. I can't tell you when it's bad enough for you to undergo surgery. It's not your family's decision. It's only yours. So we'll help you get to that place, and when you do, then we will prepare you for the surgery and educate you about that, and do all we can to optimize your condition so you have a good surgical outcome. So that's would be another discussion to go through hip replacements and knee replacements. So I'm not going to get into the specifics of what's done and how we get you ready for surgery. I'd be happy to do that at another time. So that's the overall presentation on hip and knee arthritis. So I'd be happy to take any questions or comments that anyone has.
All right. Thank you so much, Dr. Diminick. If you are watching this live, please go ahead and put your questions and comments in the Facebook Live. We will be answering questions submitted earlier and questions submitted live. Not all questions will be able to be answered, but we will get through as many as we can. I was going to asking our first question, which is, should you still engage in walking or exercise if it's painful to do so?
So you definitely want to still be exercising. The best thing to do, from a best to worst, is swimming is the best in my opinion. You don't have that pounding on your joints. You're taking gravity out of it, so that helps with your mobility. It's less painful. Next would be a bike where you can maintain the range of motion. You can raise the seat up so you don't have to bend as much, so you can still work on range of motion and strength with the bicycle. The elliptical is next best, because again, you're not getting that pounding as you do when you're walking. And then walking is the final thing, and it's a balancing act. So obviously you don't want to be inducing more pain, but if you're not exercising, your weakness will increase, your mobility will decrease, and you'll get further down the path towards surgery. So it's finding that sweet spot where you're not causing too much pain. But the best thing is to do the non-impact exercises.
Thank you. Somebody asks, why does my doctor ask me to quit smoking before they schedule my joint replacement?
That's a great question, and it's a discussion that's really important. Our goal when we do surgery is to optimize you, which means get you in the best condition you could possibly be in to have a successful surgery. And a successful surgery involves not having complications. So we know that when patients smoke, it affects their vascularity, their circulation. So it affects the circulation in and around the incision. So there's an increased risk of wound healing problems. Wound healing problems can lead to infection. And if a knee becomes infected, that's just an absolute disaster. It's one of the things that we fear the most, and do everything we can to diminish that. So decreasing smoking, eliminating smoking, because even 2 cigarettes a day has been shown to negatively impact the wound healing capacity. The other thing that smoking increases is the risk of a DVT, or deep venous thrombosis. That's when you get a blood clots in your leg, can dislodge and go to your lungs, and can be fatal. So when you see or hear on TV, a celebrity had surgery and they died 2 days later, that's almost always what it is. So smoking increases the risk of that DVT. So you have to do yourself a favor to quit smoking to decrease those risks.
Thank you. Is there a specific type of mattress that is better for people who have pain from hip arthritis to support their hip?
So not that I'm aware of, and I didn't do I'm not a paid spokesperson for Tempur-Pedic, but I think we should spend a third of our life in bed. It's just in general health, in overall, sleeping is one of the things. We try all sorts of lotions and potions to feel better and to live better. So sleeping and a good night's sleep, 8 hours of sleep, is one of the simplest things you can do. So if you're spending a third of your life in bed, having a good mattress, I think is just so important. I like sleep number beds because you go into the mattress store and you try it out for 5 minutes in the middle of a Saturday afternoon, how do you know that's going to work for you when you take it home? And so I like the sleep number, where you can adjust the height, you can adjust the firmness, and you have the whole spectrum, so you're going to find what's going to be best for you.
Thank you. Is joint replacement an option if you have rheumatoid arthritis?
It's definitely an option. So rheumatoid arthritis is different. Mostly what I was talking about was osteoarthritis, just the wear and tear that comes with living. Rheumatoid arthritis is an inflammatory condition, so it's one of many. There's hundreds of inflammatory arthritides, or conditions where you literally have inflammation in the joints, and then that inflammation actually destroys the cartilage. When that happens, many times it's multiple joints at the same time, and it's been amazing over the past 30 years how the rheumatoid arthritis has improved. So 30 years ago, it was largely treated with just prednisone, and that carried with its own risks of softening the bones, weight gain, things that were not great for patients. So they've come up with these biologic medications, and you see commercials for them every day, and they've done a remarkable job in decreasing the amount of joint destruction. So back in the 90s, a huge percentage of joint replacements were done for patients who had rheumatoid arthritis because it was so prevalent. But now the medications are working so well that fewer and fewer patients require joint replacements due to rheumatoid arthritis.
Thank you. How long does the actual surgery itself last for a hip replacement or a knee replacement?
So it all depends. There's a number of factors that go into it. So when we meet you in the holding area, that's right outside of the operating room before we take you back, and that's where you say goodbye to your loved ones. So for the loved one who's worrying about you, it may be 3 hours. It can take a long time for the whole process to be completed. But what happens during that time, it takes about 25 minutes to get the patient ready for surgery once they go into the operating room, where they are put to sleep or given the spinal anesthetic and positioned for surgery. And then the surgery takes anywhere from about 45 minutes to an hour and a half, depending on a number of factors: the patient's size, how much destruction there is in the joint. So some cases are more complex and take longer time than others. So the surgery is about an hour and a half. So that's about 2 hours where the patient's in the room, and then another 45 minutes in the recovery room till they come back out. So for the family, it's about 3 hours, but it's broken up into those blocks while we're taking care of patients in different ways.
Thank you. How long does the recovery take after a hip or knee replacement?
So it varies, of course, number of factors: age, health, other comorbidities, which are other medical problems that a patient may have, how much swelling they get, so there's a number of factors that weigh into it. But in general, by about 2 months, patients will improve. So the first week or so, oftentimes they're on a walker, then a cane for about a month to 6 weeks. And then we see patients at the 8-week mark, and probably 90% of patients are released and pretty good to go at that point. About 10% we'll see back, another month later or so, because they're not fully where we like to see them yet. But so that the majority of the healing is going to happen in those first 2 months, and then over the year it continues to improve, so that by a year you have that full recovery. But most of it's going to be in those first 2 to 3 months. So if you're taking time off, depends on how intense your job is, how demanding. Somebody who has a desk job could go back at about a month. Before that, it's really tough to concentrate and to do a good job at work. So about a month for a desk job, about 2 months for a little more demanding of a job. And if you're doing more strenuous labor, take the full 3 months that the government provides with the FMLA.
Thank you. Do all joint replacement patients need to spend the night in the hospital?
No, so that's a great question. So prior to COVID, we started doing some patients outpatient surgery. And these were, at that time, young patients, 50 years old, and no other medical problems. And, so we worked out the process for how to take care of a patient, how to get them ready, because everything has to be taken care of beforehand, so there's a seamless transition. Then COVID hit, and we had already worked it out. And then a lot of the only ways we can operate on patients were if they were going home because they couldn't spend the night. And then we started to doing it on patients who were a little bit older and found that we can do that safely, so that we've expanded. It's gotten more and more common that patients could be done as an outpatient. So I would say now probably 75% of patients are done as an outpatient, either at the surgery center or at the hospital, and they can go home the next day. If there's other medical conditions that a patient has that would make it harder, or they lack the resources at home, family and things like that, we'll keep them overnight or more if we need to. But as a lot of patients know, when we do admit you overnight, we basically wake you up every 2 hours, checking your vital signs, and then do therapy, and you're gone in the morning anyway. So patients have been very positive with the experience of going home. They're in their own bed, their own food. They get up and they're moving more quickly rather than being at the bed, being waited at the hospital, being waited on. So they're up and around. That decreases the chance of blood clots, it helps with their mobility. So most patients are done as an outpatient, but only if it's safe.
Thank you. How long after a knee replacement surgery before a patient can climb stairs?
So that varies based on strength and mobility before surgery. For sure has a big impact on how you're going to do with that afterwards. But that's certainly the hardest thing. As I mentioned earlier, it increases your weight by fourfold across that joint. So it's going to be harder. Having said that, when you're in the hospital, we do stairs. Make sure you can reciprocate it or go up and down stairs right away. You do that the first day after surgery. So it can be done. It's slow, and obviously you need railings to hold on to. So a lot of patients will find a way to spend the first a couple nights on one floor. But that will be really the last thing, the hardest thing to get back to normal is climbing stairs.
Thank you so much, Dr. Diminick. That is all the time that we have for questions today. Would you like to close?
Well, I hope this was helpful. I'd be glad to go in depth next time on how we go about the surgery, and maybe show you the ins and outs, not necessarily of the surgery, but all it takes to get a patient ready in the surgery, what we do to increase the safety and sterility of the procedures that we do, because there's so much that goes on behind the scenes. You just think about the doctor and the patient, but we probably have 12 people who will touch a patient hands-on in the course of their treatment. And so I'd like to share that with you next time.